All right, so what we do know is that there are so many more questions than answers. We're learning as we go along, and we've got good data that's coming from overseas because they've been dealing with this a lot longer than what we have as such. So we've really only touched the tip of the iceberg in learning what do we do with all of these individuals, okay? So I want to start off so we're all on the same wavelength with some basic virological factoids, okay? So we've got this major classification, this coronavirus, all right? Now, it's a single-stranded RNA virus. Now, on animals, it can really give them really horrible disease states. In humans, okay, not so. Usually that's your common cold, all right? In humans, it's relatively mild for the most part, okay? So when we look at the coronavirus, we basically have the common ones that have the lower pathogenicity. That's your common cold, okay? And then you've got the ones that are higher pathogenicity. So we had the SARS-CoV-1 that was back in 2003, so we have good data from that. We have MERS, that's the one that was associated with the camels. And then we have our good COVID-19, okay? And it's this illness, the COVID-19, is more like our SARS-CoV-1 than it was the MERS epidemic that was a while ago. How? And these slides we have to turn in, months ago, but yesterday, the Lancet published an amazing, they had a commission on looking at how this all started and what went wrong, what we have learned from the pandemic. It's about 52 pages with references, and I would say if you have an interest in this, pull that up. You can get it free online. It's really, really good because we still do not know how this all started. Was it a spillover, from a reservoir? What was the vector if it came from an animal? Did it come from that lab? So we still really don't know exactly how this whole pandemic started. It would be good to know so that we can prevent this from ever happening again, although now we're looking at monkeypox. We had a couple cases of monkeypox, and we're looking at polio. Really? Polio? Holy moly. What's next? Say that again. Oh, it's in Lancet. It's called the Lancet Commission. It just came out yesterday. I just saw it. It's really good. Just pull up Lancet and you'll see it there. Okay, so when we look at the differences or the similarities really between these three major coronaviruses, one of the things that was really different with our COVID-19 is that, and you'll see here it says infectious before ill, and you could transmit before you even had symptoms, and that was a huge issue in caring for these individuals. Most people did pretty well, but then a lot of people did not do too well at all, and we have millions and millions and millions of deaths. This is old data now because we had to turn these slides a while ago. I mean, everybody knows that it was first identified in Wuhan in China, but the thing of it is that the WHO was very smart. They named this back in January of 2020, and they called it COVID-19 because you didn't want the China virus, and it avoided the whole stigmatizing China and whatnot when it came to dealing with this virus. So that was really kind of smart. And if you don't know about the Johns Hopkins Resource Center, it's an amazing site to tell you what's in your state, what's going on around the world. It's quite detailed. Okay, so I put this in here kind of for fun. And if you look at coronavirus compared to smallpox was huge. The epidemic that started back in 1877. So it kind of gives you an idea of where does COVID fit in. I'm afraid to touch anything. Is this the light? This works? Well, it doesn't work on the slides too well. But anyway, COVID's down here. Now, these data are a little bit old, but still COVID has not outdone smallpox. And just out of sheer fun history, you know the word quarantine, where that comes from? It comes from the sailors. When they had some kind of an infectious disease, they were forced to stay on the ships for 40 days. And if you look at the Italian word, it's quaranta. for 40, so that's where we get the word quarantine from. Just in case you're on any trivia show or anything along those lines, you'll have that down pat. Okay. So, pathophysiology of COVID-19 in a nutshell, okay? So that, because we just had a nice lecture on the SIRS. So the major issue with this was when you look at the spike protein, which everybody has seen all over the place. I'm sure there's going to be some kids dressing up as a spike protein for Halloween, would be my guess. All right, so the affinity of this spike protein on the receptor binding domain, the RBD, of the SARS-2 for human ACE really determined what was going to happen to that individual. Now, we learned early on that ACE inhibitors, or ARBs, really didn't stop anything. Those are the early studies there, so it didn't matter. But very often it landed in the lung because there's a lot of ACE receptors in the lungs. And that's why we saw a lot of respiratory problems. And we really didn't know what we were doing when we first started out with this. Because it came over really November, December, hit Seattle in about December, January, because I can remember reading all those reports from them. And everybody's being put on ventilators, and we learned pretty early on that we really shouldn't do that to people as such, so that you can see as you come down here, the whole release of the cytokines, IL-6, and all of these good things, that it could hit the kidneys, it could hit, we saw a lot of thrombocytopenia, we saw a lot of bleeds with this, pulmonary edema, hypoxia, and depending upon what comorbidities you were dealing with in all ages. Because I can remember going through our unit, which is a pretty big unit, almost bursting out in tears and seeing the elderly, seeing the young. We had a 34-year-old that had 4 children. She had 5% capacity on her lungs, was on ECMO, and ended up going to the Ohio State for a lung transplant, and she did okay. So it was all age groups. It wasn't just the elderly. So it was we have a lot of studies that are coming over from China, France, and Italy, because they're the ones that really had the experience with the virus at first. But this came out a while ago, not that long ago, and they wanted to see, hey, can we look for or develop a model that would show us maybe early signs that we know that these people are going to be in big trouble, so that we might do all these other therapeutic interventions to kind of prevent them. And what they found in looking over 1,000 patients when they analyzed them, that our CRP, IL-6, age, the older you are, dyspnea, the lymphocytes, the more leukocytosis, could really pre-warn us of more severe disease as such. And we know that there wasn't any really specific signs and symptoms of COVID-19, but I think we learned early on when people would say, hey, I can't smell anything, I can't taste anything, which is still going on nowadays, and we'll talk about how to get that better, is one of the early signs there. Whoops, let me go back here. This likes to do its own thing. So let's take a look at what do we know? What does these people look like? Because it's a challenge. You're really a detective and trying to figure out, is this Memorex or is this real? Is this really from COVID, or am I dealing with something like CMV or something along those lines? What have I really got here? So the actual term for it that was named WHO and whatnot is post-acute sequela of COVID-19, or PASC, P-A-S-C. I know JAMA published the article, they call it long haulers, post-COVID syndrome. You'll see it by these names. And these articles started coming out in not until about July, August of 2020, because people were getting COVID back in December and January, and they were out of the hospital or they were not in the hospital, but they kept on with these symptoms, and it's like, what's going on? What's absolutely going on? So you saw a lot of these publications where we really didn't know what the skinny was. So this is kind of a summary of the reports of long-term COVID-19. So lots of articles, lots of TV type things, and that has really kind of settled down because people understand that, hey, this is a real diagnosis, this is what we've got. But what are we doing with all of this is another story, okay?